Welcome back to Between Two White Coats, a podcast designed to help you be the healthiest version of yourself. I'm Dr. Michelle Plaster, a family medicine doctor.
And I'm her co-host, Amber Foster, a family nurse practitioner. In our combined 30 years in medicine, we've seen a lot.
We're discussing key issues surrounding health and wellness, answering some of our biggest questions, overcoming health obstacles, and giving patient-centered advice in hopes of educating you and providing the tools you need to live a healthy life.
If you find our podcast helpful, please consider subscribing so you don't miss an episode. And don't forget to leave us a 5-star rating and review. This will help other people find our podcast.
Thanks for joining us. We look forward to serving you. Thank you for joining us today on Between Two White Coats. We have our friend Dr. Marcus Sims, cardiologist, here to help us break down and understand congestive heart failure. Welcome, Marcus. Thank you for joining us.
Thank you.
So I think congestive heart failure is one of these things that is difficult when I am discussing with patients because it has two things that you don't really want to say together, heart and failure.
Right.
And so people go, oh, I have what? I also think it's something that patients aren't really familiar with. You know, you say heart attack and most people know someone, or it's a phrase we use more, but heart failure, people probably heard, but they don't really know what it means. And heart, I try to tell patients, depending on what kind of heart failure and what's going on, it could be really devastating. It could mean that you've got do some things right and you've got a long time still to feel good and not have issues. So can you help define for us and help us understand heart failure or congestive heart failure?
Yeah, sure. So basically, congestive heart failure congestive heart failure just means that you have fluid in your lungs. The real term that we're using is, chronic heart failure. And so that's kind of the misnomer between congestive and chronic heart failure. And so usually people have shortness of breath, they have weight gain, they feel increased bloating, in their abdomen, they have lower extremity swelling. Us as, clinical folks, we can look at people and see that they have, JVD, or they have an S3 gallop, which is a sign of heart failure. We can listen to the crackles or rails. Crackles and rails are the same thing that we listen to in the lungs, and then we can see how much pitting edema they have.
This is why those cardiologists are never anywhere without a stethoscope.
Right.
Because listening to your lungs, listening to your heart, looking at the blood vessels in your neck are all diagnostic ways on just a simple exam to get highly suspicious of heart failure.
Correct.
So the symptoms are really fatigue, your get up and go is gone, you swell in your ankles more. You feel short of breath because fluid can build up in your ankles, creating that swelling. Fluid can build up in your lungs, meaning that you just can't get as much air exchange. So doing very little can make you really short of breath. Right. Climbing the flight of stairs with a laundry basket is no longer tolerable. You got to catch your breath halfway up. Those are all great reasons to make sure that you're talking to a doctor.
Right.
And then, as you said, on exam, we're going to be able to, this is one of the diagnoses that on exam you can get some really good ideas. This is one of the reasons I think people think that we're putting you on a scale every time you come in to just torment you about your weight.
Because it's always wrong. Ours is always wrong.
I just want you to
my
know,
scale says.
Yes, exactly. I was 5 pounds lighter this morning. Okay, we're just really comparing our scale to our scale last time. But you could have seen me a week ago and you're up 7 pounds.
Right.
And pushing on your ankles and seeing you got a lot of fluid in there. I can hear crackles in your lungs. You got fluid in there. And so these are all indicators of congestive heart failure.
Right.
And then how are we going to make that definitive diagnosis of congestive heart failure?
Yeah, so we're getting really, in the last, I say 5 years, getting more educated about heart failure overall in general. About 6 million people have it compared to what we were talking about earlier, coronary artery disease. 20 million people have coronary artery disease. So the big thing with heart failure versus coronary artery disease, if you come into the hospital and we find out you have blockage, we get you a stent, put you on meds, you go home, you see us as an outpatient. Folks who have heart failure are in denial, don't believe it, don't want to take the medications, and then end back up in the hospital. Or they're on meds, but they never followed up, and they never had their meds titrated up to help improve their heart function or to improve their risks that were causing them to have the type of heart failure they have. So like I said earlier, we've gotten really smart in learning more about heart failure in general. We have right-sided heart failure, but you get the right-sided symptoms with the leg swelling and the fluid in your belly, or the JVD you see in the neck, which is jugular venous distension, or you have left-sided heart failure that gets you the congestive heart failure or the pulmonary edema in our world. And so moving forward in the spectrum, now we used to have, chronic heart failure, congestive heart failure, and we knew that your heart function was less than 35%. And then lo and behold, we came out with heart failure preserved ejection fraction, which is you have a normal heart function, which is higher than 50%. And then, we get an echo done here and your heart function is 45, and now they have basically congestive heart failure or chronic heart failure mildly reduced, which is between 40 and 49%. So with that, we have kind of 3 different avenues of heart failure on the left side that we look at, and there's different ways to treat each one of those.
What are the precursors? So we're talking about congestive heart failure, but what gets someone to heart failure?
Yeah. So we have 2 paths with that. We have the New York Heart Association classification, and then we have staging. So to answer your question, if we go down the staging pathway, stage A would be somebody who has high blood pressure, they're diabetic, they've had a heart attack before, but they're not having any symptoms. Stage B would be somebody who had an ultrasound done, and on the echo it shows that they had diastolic dysfunction, or they have some valvular heart disease that's causing their mitral valve to leak, that then causes them to have pulmonary edema.
Can you define diastolic dysfunction?
There's parameters that you measure on the echo, and so we look at the E/A ratios, and that's how we determine that.
And diastole is the filling stage, and
Right,
so that's when it's more of a filling than a pumping problem.
Correct. So diastole deals with the relaxation of the heart, whereas systole deals with the contraction of the heart.
And correct to say diastolic dysfunctions, if all things continue on course, is then later going to kind of
we'll
lets
get
us
you
know
to stage C.
we're in trouble, that these other things are coming, and your pump won't be as strong down the road.
Right. So stage C would be a symptomatic heart failure patient, and stage D would be somebody who's been on medical therapy and it's not working, and they're kind of at end stage. They're on milrinone, or some kind of inotrope at home, getting ready for either transplant or LVAD. So those are the 3 stages that we look at. New York Heart Association classification, basically, New York Heart Association class 1 is an asymptomatic, patient. 2 would be somebody who has slight limitation with exercise. And then 3 would be somebody who has significant limitation with exertion. And then the 4th stage would be the end stage folks.
And I think important to look at that in both of these staging, it starts with people who don't feel it, right, who have yet to end up with negative consequences in their daily actions of the heart failure.
But it's an uncontrolled hypertension that just continues, or uncontrolled diabetes.
And when you're making your heart work harder, your heart eventually gets tired and you end up in failure. So in those early stages, when we can catch it there, we can get your blood pressure controlled, and we can get your A1Cs down and diabetes and do all the right things.
Right.
You don't have to progress. If you just keep on the road that you're on, then you're going to end up to where your heart isn't a strong pump anymore.
Right.
But you don't have to progress if we can get control of other things.
Correct. And that's kind of where I step in and help you guys and help the patient. Somebody may have a heart function of 10%, and we go down the realm of trying to figure out what their heart failure is coming from. Is it blockages in the heart? Is it a family history? Did you have atrial fibrillation that wasn't controlled, that caused it? Did you have valve disease that caused it? Did you have amyloidosis or sarcoid, or, some other esoteric thing, like I was telling you guys earlier with the Takotsubo, when the lady comes in, with a stressful event and dilates her heart, that gets better, with a beta blocker. So once you kind of figure out what you're working with, then you kind of have your cookbook or your medications that you can help somebody with heart failure reduced ejection fraction versus mildly reduced versus somebody who has preserved And the preserved folks don't do well with beta blockers, but if they have blood pressure issues that cause them to have heart failure preserved, EF, heart failure, controlling their blood pressure or controlling their atrial fibrillation or getting them to lose 20, 25 pounds, will help take that strain off their heart and they feel a lot better. So, it's all about, in heart failure, one, keeping people out of the hospital. That's from an insurance standpoint, right? Two, but in our world, we want people to feel better and have a quality of life.
And you mentioned in a prior episode when we were talking about chest pain, when we get too aggressive getting echoes, we sometimes, depending on how aggressive the cardiologist reading the echo is, and knowing that if we do an echo here in our office, the person reading that echo has never met that patient, doesn't know their symptoms, just looking at the images. And so if you have someone aggressively so that we can catch things really early, it can also create diagnoses that can prevent you from having life policies and things of that sort. And if you really want to be aggressive, get your life policy set up for insurance and then go get all your testing done.
Correct.
How would a person know in the asymptomatic phases? And of course, we're always trying to get you to get your sugar controlled and get your blood pressure controlled and eat right and exercise and do those things. But how does a person know who should be getting echoes, or what kind of workup should we be doing even to identify these people to get them to you?
So depending on your risk profile, if you have 3 or more cardiac risk, or if you're diabetic, then I would say get an echo, because you're going from basically, stage A to stage B when you get the echo. And if you see they have diastolic dysfunction or valvular abnormalities, or if their EF's down some, then you kind of have to go get the stress test, then get the cath to see if they have blockage. If they don't have blockage, then you put them on, appropriate medications in order to improve that heart function, whether it's mildly reduced or if it's, severely reduced.
And if I'm listening to this and trying to figure out if I have 3 or more cardiac risk, what are all those different cardiac risks that?
Yeah, I would say, high blood pressure, cholesterol, diabetes, if you have peripheral vascular disease, had a prior stroke, you've had a history of arrhythmia like atrial fibrillation or aflutter,
smoking,
morbidly obese, definitely smoking, alcohol, because you can have, alcohol-induced cardiomyopathy. So once you stop drinking, and we put you on the medications, then your heart function gets better. And a lot of people don't want to take the medications, right? So say if your heart function was 10 to 15% or 5%, now it's back to 55, 60. Do I have to continue to take the medications? And the guidelines from the American Heart and American College of Cardiology say continue the medications because it's going to help you, relieve your symptoms, quality of life, and help you basically from a mortality, morbidity standpoint.
So then what is as we've identified these people, we get them over to cardiology and we're trying to make sure that it doesn't progress, that their heart stays as strong as possible. What are the treatment options?
Yeah, so for heart failure reduced, we go with quad therapy. So that's basically aldactone, SGL2s, so your Jardiance, your Farxiga.
Which are approved as diabetes medicines initially, and then wonderfully came on to find that they are also now approved for treatments for heart failure. Right,
and it's all kind of neurohormonal pathway for those medications, and what they found that helps keep people out of the hospital. But beta blockers been around forever, tried and true, so usually we won't put them on tartrate, which is a BID. It's either metoprolol succinate or Coreg for the heart failure reduced.
And this is important, I think, for people with heart failure to hear. And I think it was a talk you were giving forever ago that I was listening in on a cardiology conference, that metoprolol succinate, the once a day, is approved for heart failure and aids in heart failure, where the tartrate twice a day is not the same.
Correct.
And succinate was still branded, tartrate was generic, and you could go to your pharmacy and they will just think they're doing you a favor and flip you to the cheaper one.
Right.
So if you are on metoprolol for heart failure, make sure you continue on the once a day one. It's not the same to switch it to the BID.
On the succinate, correct.
Yeah. Yep. So beta blockers, we said aldactone, SGLT2s, beta blockers.
And then the final kind of layer in that is ACE or like lisinopril, or ARBs like losartan, or the new ones are the ARNIs, the angiotensin receptor, one called Entresto. So what I normally try not to put people on lisinopril, because if you have them on lisinopril and you're transitioning them to Entresto, then you have to have a 36-hour washout period. Well, who waits 36 hours to change from one medication to another?
Especially when that medication was controlling your blood pressure.
Right.
So we're just going to have 36 hours of high blood pressures and hope for the best.
Right. So I've been leaning more toward.
You just started on Entresto.
Well, I started my, yes. But before that, say, losartan, I put them on losartan, and then I can just transition them to Entresto without a washout period.
Okay.
Versus
go with the
going from,
That's helpful.
and then, because, then you're telling the patient wait 48 hours without their medication and the blood pressure sky high. But yeah, so.
And when you say quad therapy, it is all four.
Yep.
And so we're not just going to, and this is where I think people sometimes say, oh my gosh, I went to that cardiologist and he started me on 4 medications. Now I have 4 new prescriptions. I'm taking this handful of pills. But all 4 of these work in different methods to help protect your heart.
Yep. And
if we are not protecting your heart, then it's going to get to the point where the pump doesn't pump very strong.
You're going to still be symptomatic. You're going to feel like crap. Your quality of life sucks. And so, we put you on those medications because we have the clinical data to back it up, and we have the support from the American Heart Association, the American College of Cardiology. And so, we're all busy, and most of the time, they want you to titrate the medications up every 2 weeks until you get to the maximum dose on all 4 of those, which you really don't have to titrate the Farxiga or Jardiance. Aldactone, you could start at a 12.5, but why? Just put them on the 25, and 2 weeks later, check, their labs, make sure the potassium's okay. And then with the beta blocker, ideally, you want to try to titrate up, as long as you don't have severe bradycardia, fatigue, and weakness, to the max dose of either the succinate or the carvedilol. And with carvedilol, they do have a once a day, and they have a BID. So if you have some compliance issues, try to lean towards, the once a day. And then Entresto is a BID medication, and you want to get that to the highest dose.
And what blood pressure is too low for a person with heart failure?
Yeah, so a lot of times people who have heart failure, their blood pressures sometimes will be down, 90s over 60. So my lowest cutoff is 90 over 60. So, some people get nervous if it's less than 100, say it's too low for me.
Yeah.
But we're trying to improve your heart function, your quality of life, and your symptoms.
Yep. And beating against a lower pressure, I'll tell patients, is less work on your heart. And we're trying to make your heart strong and not give it extra work and not make it enlarged.
Right.
And so you expect a low blood pressure. And I ask this question just to kind of help reassure people that these people who've been living their life at 140 over 95, and they go, that's my normal.
Right.
No, that's why you have heart failure, because you got so comfortable saying that number was okay.
Correct.
So now we're going to push you to, top number systolics 100 and less. And I'll often remind patients, it's if you are tolerating, it's not everyone can be 90 over 60. They'll stand up and things will go black for them, or they'll become a fall risk because they're dizzy or lightheaded or too washed out, fatigued.
Right.
And so typically what we're trying to do is push your blood pressure to be as low as you feel okay.
Correct.
And give your heart less work.
Yeah, and that's the thing. Even people, if your heart rate's in the 50s, if you're asymptomatic, then I'm okay with it. But if you're, falling out, or, won't get off the couch because you're fatigued and weak, then we need to make some changes and see what really works for you to make you feel better.
Well, and I don't think people realize heart failure can affect so many different people, and I'm totally putting my medical assistant on blast, but my medical assistant here, Bree, had cardiomyopathy after pregnancy, and so she went into heart failure.
Postpartum cardiomyopathy. Yep.
And she is on some of these medications, and we laugh because she'll say, I can tell my blood pressure's going up, if she's working with me, because why wouldn't your blood pressure go up if you're working with me?
Oh yeah, you're bringing it.
And so, and
like she can tell now when her pressure is higher than it should be because she's now used to it running.
Sure.
And she's a young woman.
And she's young. She's in her 20s.
Yeah.
And so, but she's on she's on the 4. And so she feels so much better in her ejection fraction. We're so proud it's now at 40% where it had been like 17.
Right.
And to know Bree is to know that this is not a breach of HIPAA because she will tell everyone. She will run through the office and let me know. My EF is now, my ejection fraction is now. Like, good for you.
Yeah.
So, like, I think people don't realize that it's not just an old people disease. It's not just like your 90-year-old grandma's walking around with heart failure and the legs that look like elephants. It can be someone in their 20s who's had a complication of pregnancy, or someone with hypertension who just was untreated for years in their 30s,
or a
heart transplant.
Viral cardiomyopathy where you get a virus and it finds your heart, and that happened with people with COVID.
So I think it's not just an old person. I think that when people think congestive heart failure, they think end stage, and they think like, oh, well, they're on that Lasix and they can't go to the shopping today because they had to take their Lasix, and they're worried about, we'll have patients that'll skip their diuretics because they're terrified to come into the office.
Well, yeah. So you bring up a good point. So for the heart failure reduced folks who get on Entresto, it actually has natural diuresis in it. Yeah. So a lot of times once you maximize the Entresto, then they can come off the Lasix altogether. So, it's kind of a win-win. No more diuretic.
Helps their quality of life. Also doesn't wash out their potassium and sodium. And
and then they get to stop one medication, But another point you made, people look at their ejection fraction. So, with the reduced, every 30 days, I try to get it up to that 90 days. Some insurance companies say, well, just maximize their medications and then do it at 90 days because they're looking at it as a cost savings mode. But I'm looking at it, if I do it at 30 days, patient doesn't want to take the quad therapy, right? But they see that their heart function went from 5 to 25. They're like, okay, the medications are working. And then you titrate up again, and then they go up into, 45. And then lo and behold, they get to normal. And then they want to ask you, can they stop the medication? You say, well, if we stop the medication, you may go back down to 5. Yeah. And nobody wants that. That's why you see Bree running around. I got EF of 41%. I want everybody to know, I'm doing all the right things. Yeah. I'm helping myself. And so that's what you really want.
Yeah. Marcus, I know specifically you were telling us before we started recording about your dad and even why you were called to become a cardiologist. Right. And I think it's a great story about why heart failure matters. Do you mind sharing that?
Yeah. So, there was a write-up in one of the local Gwinnett magazines, but I'll send it to you. But essentially, I always either wanted to play soccer or be a physician. And I had an injury when I was 16. Which basically almost took sports away from me. I was kicking 60-yard field goals. I went to Redan High School in Stone Mountain, Georgia, where Kevin Butler went to school, who was the first person who helped UGA win their national championship. And then Chris Gardocki, we played soccer together, and he went to Clemson. And then when Kevin Butler was at the Bears, the 85 Bears who won, he didn't want to do all the field goals and kickoffs and all that. So he got the Bears to draft Chris Gardocki. Oh, wow. And so then I was supposed to be the next one in line, and tore the ligaments in my neck and had to have a fusion of C5, C6. So my mom basically said, well, you said you wanted, to be a football player, soccer player, and you wanted to be a doctor so you could still be a doctor, which at 16, you don't want to hear that as a kid.
Right. That's so much less glamorous.
Right. So fast forward, go to college, did physical therapy that summer, and the doctor told me I couldn't play sports anymore. And we had just won the state championship in soccer in '88, and then I went to the Final Four and rehabbed the whole summer. And I asked him, can I play soccer? He was like, as long as you don't hit the ball, which, we're going to hit the ball anyway, typical male. But I ended up going to Queens University in Charlotte on a soccer scholarship, just got in the Hall of Fame.
Congratulations.
Induction in February, so that was cool. And then went to Morehouse School of Medicine, and where I thought I wanted to do primary care and thought I wanted to do OBGYN or, be a family physician.
Right, the glamorous parts of medicine.
All day. But, in medical school, we trained at Grady just like the Emory students. And when I was there, a lot of those folks need help. And you don't have all the resources that you would have at a Piedmont or an Emory or whatever. Right. And so me being at Grady and having to do my own vital signs and my own blood draws and my take my patients down to X-ray or CT scan, because when you meet with the attending and you don't have any of that done, they're going to be upset.
Get it done.
Yeah. So when you go to the University of Florida and you got the Gatorade and the Coke products and you have your own residence room and there's carpet in the hallways and, medical students are wearing long coats down to their ankle, which if you were at Grady, or
You wear a short coat.
or institution that, believes in the hierarchy, you're going to wear the medical student coat, and then you're going to wear the resident coat, then you're going to wear the fellow coat, and then you get to the attending status, not the long coat with your name embroidered on it, and you don't know how to check, blood pressures, but not shooting any shade at University of Florida, because they helped me get where I needed to be.
Just different. I trained at Cook County in Chicago as well, and it's just when you're at these community hospitals, it's just different. It's a great place to learn.
Right.
But it's, God bless the people who work there every day, because it's a heavy lift.
Right. But then, you globally learn to appreciate the help of everybody, not, just one select, group of people. And so I think that just helps you to be a better overall physician. And so when I did my internal medicine rotation, after I did the family practice, after I did the OB, after I did the psych, after I did surgery, I said, if I don't become a cardiologist, I wouldn't mind just doing internal medicine. And so, God's plan for me at that time was Morehouse School of Medicine. Your fiance is at Morehouse. She's 2 years behind you. I know you want to stay here because your dad is sick with heart failure and they're putting him on the transplant list at Emory, but we want to send you down to the University of Florida because I have two guys down there that were presidents of the American College of Cardiology, that if you do your best, they'll write a letter for you, and then you'll be able to go wherever you want to for cardiology. So with that being said, when I was in medical school, found out my dad, had a heart function of 5%. He was in his 60s, so you're young enough, unlike Cheney, who was too old to get a transplant, but he got a transplant, right? And so we're going through the workup at Emory for him to get a heart transplant. And basically they checked his PSA levels and found out his PSA level, was like 40. Oh. So now we have to go to urologist, and urologist, does his evaluation, sets him up for a CT scan, and finds out that his prostate cancer has spread outside the capsule. Mm. So now we not going to Emory Cardiology to get the pagers, to get on the transplant list, to get a transplant because, you have prostate cancer that's spread outside the capsule. And because you have prostate cancer, you can't get a transplant. And because you have severe heart failure, we can't do anything about your prostate. So we're just going to put you on, therapy that's going to slow down the progression of your prostate cancer. And when you go to medical school, you find, when people hear the word cancer, we all freak out, right? Like,
I know, anything.
Oh my God, he's going to die from cancer. And so you start medical school like I did, and you go talk with Dr. Paulding, one of our professors there, and he's like, prostate cancer that he has is slow growing. He's not going to die from that. He's going to die from something else. So I knew it was going to be his heart. Mm-hmm. And so back then, the therapy was beta blockers, digoxin, and Lasix. And then came out lisinopril, which when I talked to my dad, probably like your dad's, I just take the red pill, blue pill, green pill, whatever my doctor tells me. I don't know what it's for. And I'm sitting there like, are you kidding me? Because we're educated and you got to know what you're taking. You can't just be ingesting these things, But he took the medications that were offered to him, which, like I was telling you, in today's society, he would have had a defibrillator.
Right.
But he didn't have a defibrillator because back in 2001, that wasn't the standard of care for somebody who had a heart catheterization with no blockages, because there was a lower risk, of having cardiac arrest from non-ischemic cardiomyopathy. But we have these life vests now, right, that insurance companies won't pay for, or wearable cardiac defibrillators, because now we have two companies. And I used to talk for Zoll, and when you talk to physicians out in the community, especially cardiologists, they were like, well, the risk isn't that high for non-ischemics versus people who have coronary artery disease or have bypass surgery who have a low EF less than 35%. And I'll sit there and tell them I don't give a shit what the data shows, because my dad is an N of one.
That's right.
Who, if he had a defibrillator, he wouldn't have died on Christmas Day, you know, and my family's there, and I'm down at the University of Florida.
Being a resident.
Yeah.
Didn't get the day off. Didn't go home for Christmas.
And nobody else in my family knew how to do CPR, right?
And that's exactly right. That all the numbers in the world don't matter when the number is you or someone you love.
Right.
Yeah.
And so, you know, again, back to what we were talking about, right? You want people around you or helping people in your community who want to treat people like they are an extended part of the family.
Yeah.
And so, yeah, I'm an interventional cardiologist because I like the plumbing aspect of the wires and balloons and stents, but also I'm passionate about heart failure. I'm not board certified in heart failure, but I'm a general cardiologist, and there's plenty of cardiologists in the U.S. who treat people with heart failure. And as long as you practice guidelines and you get people feeling better, where they can go to their, you know, grandson's, you know, baseball game or soccer game, where 2 months before they couldn't go do anything.
Yeah.
You made a big impact,
Huge impact
on the family.
And add days to their life. And I'm so glad that you were called to cardiology. You are a great service to our community. When my dad says I take the red pill that my cardiologist tells me to take, that person who tells them to take it is you.
Right.
And I'm like, you do what Dr. Sims says, Dad.
Right. Plus you get a text, you know.
And,
like,
yeah, that's exactly. And I will know
right.
what the red pill is because you have already told me. So we are so grateful for you. We are grateful that you have passion for heart failure too, as although you practice a lot of interventional, because there are people who are heart failure specialists. There are clinics that do only heart failure,
Correct.
but there are not enough of them.
Right.
And they are sometimes a long wait to get into.
Correct.
And so we appreciate the general cardiologists that are also extending into doing these things to make sure that they get done. If someone has heart failure and they feel like it's not being well controlled, they continue to be symptomatic, then a heart failure clinic is a good place to also look for and land in our area. Our heart failure specialists exist where I know we've had
in
some at Piedmont
Snellville,
has
East Side, and we're working on getting a clinic in where our
perfect. And
on the third floor. Yeah, we're on the second floor.
And we
Snellville, but third floor.
Piedmont has some people in Athens now that we have people at. I'm so thrilled that we'll have people in Snellville as well, so that we can go either direction to make sure people are covered.
Correct.
Thank you so much for helping us understand
Thank you.
heart failure and sharing your story with us. And thank you all for joining us.
We like to leave you on a good note. So today's something good is accomplishments. My 12-year-old decided he wanted to get better at basketball, and I told him, well, you got to put in the work, buddy. So he started practicing nonstop. He joined an AAU team. Every opportunity he gets, he puts into it. And he just recently was acknowledged by the high school coach at his school, recognizing how far he's come, how much better he has improved, how much he has improved, and how his fundamental basketball is so much better. And to see him say, I worked hard and now I'm doing better, was just the most fantastic thing for a parent. Thank you so much for joining us today. And until next time, take care of yourself.